In this video module, we're going to discuss the clinical application of opioid pharmacokinetics. Most immediate release opioids follow first-order kinetics. In other words, steady-state serum drug concentrations change proportionally with dosing. These opioids include codeine, fentanyl, hydrocodone, hydromorphone, morphine, and oxycodone. Notable exception is methadone. So let's take a closer look. If you look at a graph of concentration versus time, the time to Cmax for an IV opioid is 10 minutes. The time to Cmax for sub-Q or IM is 30 minutes, and the time to Cmax for oral immediate release formulations is an hour. Another word for the time to Cmax is the peak effect. And all of these opioids, and including the immediate release formulations for oral, have a half-life of 4 hours. Okay, so let's take a closer look. Oral immediate release formulations. Onset, 20 to 30 minutes. Time to peak effect, an hour. Half-life is 4 hours. Time to steady state concentration is 5 times the half-life, so 20 hours. IV formulation, onset 1 to 2 minutes, time to peak effect about 10 minutes, half-life 4 hours. Steady state concentration is 5 times the half-life, so 20 hours. Okay, so what does this mean? So you get an opioid naive patient, and let's say they have constant pain. So what you would do is you would schedule their immediate release opioid once every half-life, so once every 4 hours while awake. Then, once the pain is controlled, you can convert these routine doses to extended release formulations. The other option is you can just go straight to extended release formulations if you know what the patient's requirement has been in the last 24 hours. Now, regardless of what formulation you start, you have to know the half-life of these formulations, because then you do 5 times the half-life, and that's the time when it reaches steady state concentration, and that's the time when you can titrate up the dose. For breakthrough of constant pain, or if you just have intermittent acute pain, you can dose an opioid once every time to Cmax as needed. All right, so let's see if all of this made any sense. Our case is RW is a 67-year-old female with metastatic breast cancer with metastases to bone and is taking oxycodone 5 milligrams POQ4 PRN pain. She asks you, how soon after I take my pill will I feel its peak effect? Your response is, what's the peak effect of immediate release oral oxycodone? I'll give you a minute. If you said 60 minutes, you're correct. After 2 weeks of taking oxycodone PRN, RW has tracked in her pain diary that she takes an average of 8 tablets per day. Recent scans shows disease progression in the bone and new metastases in the lung. You decide to start her on oxycodone sustained release, and you do the math, and you come up with 20 milligrams POQ12. And you continue her oxycodone 5 milligrams POQ4 PRN pain for her breakthrough pain. When is the soonest you could evaluate and assess the need to increase the oxycodone CR dose? Well, you would need to know what the half-life of the oxycodone CR is. So let's say you look it up, and it's not far from the immediate release oxycodone dose, or oxycodone half-life. So it's about 4.5 hours. Now remember, you can't titrate to the next dose unless you reach steady state. So when are you going to reach steady state with this sustained release oxycodone? If you said 24 hours, you're correct.